Neurology quiz number 130. Describe the mechanism of action, indications and side effects of the various neonatal Fc receptor or FcRn antagonists used in the treatment of generalized myasthenia gravis, GMG. The neonatal Fc receptor or FcRn is structurally related to MHC class proteins, although its function is different. FcRn is so named because when it was first discovered, it was noted to transport maternal IgG antibodies across the placenta to provide passive immunity to newborns. Since it binds to the Fc portion of IgG, it was named the neonatal Fc receptor or FcRn. It is composed of a heavy alpha chain in beta-2 macroglobulin. It is encoded by the FcGRT gene. Major sites of expression are the endothelium, liver, kidney, placenta, epithelium, muscle, and immune cells. Major functions of FcRn. Number 1, IgG recycling. It protects immunoglobulin G from lysosomal degradation and extends its half-life. Number 2, placental IgG transfer. It is responsible for maternal to fetal passive immunity. This slide shows how FcRn protects IgG from degradation and the mechanism of action of FcRn inhibitors. In figure A, IgG is ingested into the endosome of the endothelial cell. Acid pH promotes binding of FcRn and IgG. Majority of IgG bound to FcRn is protected from lysosomal degradation and released back into the circulation. Small amounts of unbound IgG enter the lysosome and are degraded. In figure B, FcRn inhibitors bind to FcRn, and thus IgG ingested into the endosome is unable to bind to the FcRn. All the unbound IgG enters the lysosome and is degraded and is not returned into the circulation. FcRn inhibitors. The FcRn inhibitors are a newer class of targeted immunotherapies for generalized myasthenia gravis. Inhibition of FcRn accelerates breakdown of circulating IgG pathogenic antibodies such as acetylcholine receptor and MuSK antibodies. This mechanism produces a relatively rapid reduction in pathogenic IgG autoantibody levels. Unlike traditional broad-based immunotherapy, this is achieved without affecting other immunoglobulin levels and without suppressing T cell, B cell, or complement function. Currently approved FcRn inhibitors. Number 1, Efgartigimod or Vyvgart. It is an engineered human IgG1 Fc fragment and binds FcRn with high affinity. The IV formulation was initially approved for acetylcholine receptor antibody positive generalized myasthenia gravis. Approval was based on the ADAPT trial. As of May 2026, the FDA has expanded approval of both Vyvgart and Vyvgart Hytrulo for adult patients with generalized myasthenia gravis, regardless of antibody status. Approval now includes acetylcholine receptor antibody positive, MuSK antibody positive, LRP4 antibody positive, and triple seronegative generalized myasthenia gravis. The expanded approval was based largely on the phase 3 ADAPT-CERON trial. Dose is 10 milligrams per kilogram IV infusion. If the body weight is more than 120 kilograms, fixed dose of 1200 milligrams. It is given once weekly for 4 weeks and each infusion lasts about an hour. Retreatment. Additional cycles are based on clinical response. In the clinical trials, retreatment usually occurred when symptoms recurred. A new cycle is usually started no sooner than 8 weeks from the beginning of the previous cycle. Subcutaneous formulation with hyaluronidase or Vyvgart Hytrulo. It was initially approved for acetylcholine receptor antibody positive generalized myasthenia gravis. Approval was based on the ADAPT-SC study, which showed comparable efficacy to the IV formulation with similar IgG lowering, rapid administration, and improved convenience. Subcutaneous route is 20 to 30 seconds by syringe and 30 to 90 seconds by infusion. It is a fixed dose of 1008 milligrams plus hyaluronidase weekly for 4 weeks. Future cycles based on clinical response, generally no sooner than 50 days from the start of the previous cycle. The subcutaneous form is also approved for CIDP and is administered weekly and not in cycles. Onset of action. Many patients begin to notice improvement within 1 to 2 weeks after the first infusion. Maximal clinical effect usually occurs around 1 to 2 weeks after completion of the 4-dose cycle, approximately 4 to 6 weeks from the first infusion. Common adverse effects are usually mild to moderate. These include upper respiratory infections, UTI, injection site reactions, which are more common with the subcutaneous route. It is overall generally well tolerated with favorable long-term experience. Number 2, Rozanolixizumab or Restigo. It is a humanized IgG4 monoclonal antibody which causes direct FcRn blockade. It was the first FcRn inhibitor approved for both acetylcholine receptor positive and MuSK positive generalized myasthenia gravis. The approval was based on the MyCaring trial. It is given by subcutaneous infusion but is not self-administered. Dosing is weight-based subcutaneous infusion, less than 50 kilograms 420 milligrams, 50 to 100 kilograms 560 milligrams, and 100 kilograms 840 milligrams. It is given weekly for 6 weeks. Therapy is cyclic. Minimum interval between cycles is 63 days or more from prior cycle start. Adverse effects: headache is the most common. Incidence is 44% in trials. 5.3% had severe headaches. Other adverse effects include fever, diarrhea, infections, hypersensitivity, injection reactions, and rarely aseptic meningitis. Number 3 is Nipocalimab or Imavi. Nipocalimab is a fully human monoclonal antibody that blocks the Neonatal Fc receptor. It is FDA approved for adults and adolescents more than 12 years with acetylcholine receptor positive and MuSK positive myasthenia gravis. Approval was based on the Vivacity MG3 trial. It is associated with 70 to 75% reduction in IgG. Dosage is 30 milligrams per kilogram loading dose, then 15 milligrams per kilogram every 2 weeks. Therapy is continuous rather than cyclic. Improvement occurs 1 to 2 weeks after the first infusion, but some patients may improve within a few days. Common adverse effects include respiratory infections, peripheral edema, muscle spasms. However, overall it demonstrates favorable tolerability. Comparative analysis of FcRn inhibitors. IgG reduction. Approximate reductions in IgG are 61 to 66% with Efgartigimod, 73% with Rozanolixizumab, and 75% with Nipocalimab. Nipocalimab is reported to achieve the fastest reduction in IgG levels, and there is sustained suppression due to continuous dosing. Cyclic versus continuous therapy. Advantages of cyclic therapy are presence of drug-free intervals, which allows greater flexibility in treatment, and tapering and weaning is easier. Disadvantages of cyclic therapy include intercycle deterioration as IgG levels recover, and therefore severe disease may require more frequent therapy than is currently validated. Advantages of continuous therapy are less fluctuation and stable disease control. This may make it more suitable for severe MG. Disadvantages include less flexibility, harder to taper, and continuous immunologic suppression. Therefore, Nipocalimab may be preferable for severe disease, while cyclic agents may suit milder or more stable patients. FcRn inhibitors versus conventional immunosuppressants. With FcRn inhibitors, improvement is often seen relatively quickly compared with traditional immunosuppressants such as mycophenolate or azathioprine, which may require months for a maximal effect. After FcRn blockade, IgG degradation increases almost immediately and pathogenic antibody levels fall within days. Neuromuscular junction function can begin improving within 1 to 2 weeks of the first infusion. The tempo of improvement is somewhat analogous to IVIG and PLEX because all three reduce the effects of circulating pathogenic antibodies relatively rapidly. However, FcRn inhibitors provide a more sustained reduction in IgG. A reasonable clinical expectation is time after starting 1 to 2 weeks, early symptomatic improvement possible, 3 to 6 weeks clearer functional improvement in many patients, and 2 to 3 months more maximal and stable benefit. Role in myasthenic crisis. Myasthenic crisis is an IgG-mediated emergency with IgG antibodies impairing neuromuscular transmission. Traditional rescue therapy are PLEX and IVIG. Both act rapidly by reducing pathogenic IgG activity. FcRn antagonists are usually not as immediately effective as plasma exchange. Improvement after plasma exchange begins within 2 to 5 days, sometimes even sooner. With IVIG, improvement is usually seen in 4 to 7 days. With FcRn antagonists, improvement generally begins 1 to 2 weeks and peak benefit often later. Currently, standard therapy for myasthenic crisis remains PLEX or IVIG along with steroids, ICU support, etc. And FcRn antagonists are not yet replacing these therapies. However, situations where FcRn antagonists may be useful include refractory crisis. Patients who fail IVIG and PLEX relapse quickly or have repeated crises. Bridge therapy after stabilization. For instance, patient in crisis is stabilized with PLEX. FcRn antagonist is started afterwards and helps maintain low IgG levels and prevents rebound worsening and allows added standard immunotherapy time to take effect. FcRn inhibitors in pregnancy. FcRn has a critical physiologic role in pregnancy. FcRn in the placenta transports maternal IgG to the fetus, providing passive immunity. Therefore, blocking FcRn during pregnancy could theoretically reduce transfer of protective maternal IgG to the fetus, resulting in neonatal hypogammaglobulinemia and infections. For the currently approved FcRn inhibitors, there is still limited pregnancy data, and they are usually avoided during pregnancy. Vaccination. Live vaccines should generally be avoided with FcRn inhibitors because these drugs lower circulating IgG antibodies, which are important in the immune defense against infections. The weakened organism in the vaccine may replicate more extensively than intended. There is therefore a theoretical and sometimes a real risk of vaccine-associated infection. Interactions. IVIG. FcRn inhibitors can reduce effectiveness and duration of action of IVIG because they accelerate the degrading of administered immunoglobulin G, including the immunoglobulin G contained in IVIG. Because of this interaction, it may be advisable to avoid overlapping IVIG and FcRn inhibitors unless clinically necessary. PLEX with plasma exchange FcRn monoclonal antibodies may also be removed. Therefore, it may be preferable to give FcRn inhibitors which are monoclonal antibodies once PLEX is completed. However, currently there are no standardized protocols.